So this is more of a clinical approach to the anaplastic or neuroendocrine or AR negative or intermediate atypical carcinoma patient. So um, again, this was the view from the top of Sulphur Mountain, just behind us. So the key points that I want to make in this 15 minutes are: when do I consider the neuroendocrine phenotype, either de novo or treatment emergent? When do we consider obtaining tissue for diagnostic studies, molecular profiling, a research or commercial assay? And how do we manage patients? The NCCN basically just says manage per small cell guidelines, but I hope to bring a few more nuances than that. Some of the platinum-based regimens and then some of the clinical trials that are out there. So this is a case to challenge you. This is just from the past year in my cancer center, and a patient that I managed over several years, a 75-year-old African-American male from Durham. He had T3 Gleason 10 prostate cancer, PSA of 50 at presentation. He actually did not have metastatic disease that was detectable by scans, and he was treated with long-term ADT and primary radiation. He actually achieved a pretty good PSA nadir several years later, but within about a year of stopping ADT, he developed rapid PSA kinetics. PSA rose from 2 to 50 and developed progressive node-only asymptomatic disease on CT. He was treated with CYP-T followed by abiraterone, achieved a pretty remarkable response. His PSA declined to 6 from 50, but then his PSA started to drift upwards again. So these drifters, as per Howard Scher, so 6 to 11 about a year later, and he developed again progressive symptomatic adenopathy in the right pelvis when he was, which was now symptomatic, and he developed sciatica down his right leg. And so how many of you guys in the audience think of this as neuroendocrine prostate cancer? Right, I didn't either. So we did a biopsy, and in his diagnostic biopsy, preceding his radiation, probably Jyoti should review this, but there were no small cell adenocarcinomas present. This was high grade, Gleason 10. I'm sure there were neuroendocrine cells present, but this was not called as a small cell. In his post-abiraterone core biopsy of the lymph node, you can see synaptophysin staining on the left, absent PSA staining on the right. This is, I don't know if this is intermediate or full small cell or a transitional hybrid or whatever we're going to call this. This is bad. Okay, so neuroendocrine prostate cancer. And Jyoti has reviewed this well. I'm going to just talk a little bit more about it clinically. It is a distinct clinical phenotype, but we're really still coming up with the appropriate definitions, both molecularly and phenotypically. It was first described in 1977, and as we know, it can be either de novo or it can be treatment emergent. De novo is about 1% of prostate cancers, but treatment emergent, as you'll see from many of the stand-up to cancer biopsies, seems to be increasingly common. It has been linked to amplifications of certain genomic loci, such as the NMYC loci and aurora kinase. And elegant work from Misha Beltran has actually shown that NMYC amplification can promote a neuroendocrine differentiation pattern, and that when you block that with a drug, an aurora kinase inhibitor, which interacts with NMYC, you can actually reverse that neuroendocrine differentiation in some cell lines. In these tumors, there's also been common activations of the PI3 kinase AKT pathway, but that's also true in CRPC as well. PTEN loss is relatively common, low AR activity. EZH2 seems to be high, which can promote EMT and metastasis. Low RB1, Dr. Lotan at Hopkins has found a very good biomarker, either with cyclin D or through RB1 being low, indicating a high proliferation rate, high Ki67, and as Jyoti mentioned, P53 mutations are enriched in these patients. This is a viscerotropic disease that's low PSA producing, and neuroendocrine markers in the serum are variably expressed. So I typically consider neuroendocrine prostate cancer when a bulky non-PSA producing disease occurs. And this is fairly obvious when it occurs de novo, but when it occurs after prolonged treatment with AR therapies, it's not as easy to decipher. So a high burden of disease after progression on an AR-directed therapy, a relatively low PSA, like the patient I presented you with, and modest PSA progression. It may even meet the working group 2 or 3 PSA criteria, but perhaps it's not a AR-driven tumor, where PSA is just drifting, but the bulk of disease is taking over the patient's body. Visceral metastases, especially liver, high LDH, although I think in the West Coast Dream Team, the neuroendocrine phenotype wasn't particularly enriched in the viscera. It was also found in bone and lymph node, which is calling that into question. So this PSA to LDH transition would be a good place to start to consider this anaplastic or poorly differentiated neuroendocrine phenotype. Whether we should consider this in all patients who are failing ABI and ENZA. Certainly when you see a paraneoplastic syndrome, we've had a few cases at our center of SIADH or Cushing's or hypercalcemia, even in the treatment emergent setting. You should consider that. You know, Misha's cancer discovery paper was very interesting. It really showed that treatment emergent NEPC can occur out of clones that really harbor the TMPRSS2 ERG fusion, that these clones then go on to lose AR expression, as you can see in these slides from the same patient. And so there is really a division, I think, in the field, and perhaps both may be correct in some patients, where you can see plasticity, this transition from the typical lumen to heaped up cells which invade the basement membrane. They acquire an epithelial or mesenchymal status. They differentiate and they spread into the bone. Some of those reawaken from dormancy. Some of them spread to viscera, where we can reawaken a neuroendocrine pathway. Some of those are dead ends into lymph nodes, and they may even have a different metastatic pattern. So this epithelial plasticity may intersect with the neuroendocrine differentiation. But it could also, as Jody mentioned, be clonal evolution. We know that polyclonal metastases can develop in certain patients, that those clonal metastases can repopulate existing metastases, that metastases can metastasize even back to the primary, where you can have self-seeding. And so it becomes a very puzzling conundrum of, when you're observing a patient with a mixed response, is that clonal heterogeneity or plasticity. And we know that that plasticity can arise through epigenetic lesions, mutations, genomic rearrangements, transcriptional rearrangements, and the tumor microenvironment itself. This is a great paper. If you haven't read it, you know, it really characterized some patients as being this linear metastatic pattern, versus patients where it really looks like a metro map of London, where the metastases are just intersecting all over the place. And so I showed this slide in my first talk on enzalutamide and resistance. And again, from my reading of the paper, and maybe I need to reread this, but on the East Coast Dream Team, which is on the left here, most of the patients were ABI-ENZA naive, but I'll have to look back at this, but at least in their pathology, again, not formalin fixed, most of these patients did not harbor a neuroendocrine phenotype, but again, didn't apply your criteria and weren't able to do that on a frozen section. On the West Coast, this is the proportion that had the intermediate adenocarcinoma or intermediate atypical carcinoma variant. It was about 26%, where another 26% harbored mixed criteria. And the small cell was a smaller proportion, but 13% was still, which was still greater than the East Coast team. When you look at the patients in terms of their serum markers, you do see serum chromogranin in a proportion of patients, even with the intermediate atypical carcinoma. Serum chromogranin seems to be elevated just to the same degree as pure small cell. So in a patient that I suspect to have a atypical carcinoma or a neuroendocrine transformation, I think it's worth checking the serum chromogranin to see if it's elevated, whether it could be a useful biomarker, much like PSA, to follow over time. And as well, neuron-specific enolase is a serum biomarker where that may give a clue as to the emergence of that. I think LDH, circulating tumor cells, if you can get that covered, may be a helpful biomarker to follow and track longitudinally as you follow a patient. Jody showed this data that really the poor survival of these intermediate variants really calls to attention that we should have a real pathology consensus around these definitions, so that we can inform our patients about prognosis and treatment options, and ideally select them for therapies directed at AR negative or maybe AR expressing but not addicted tumors. Chromogranin has long been known to be a poor prognostic finding, so an elevated chromogranin in this series really was associated with rapid progression. CNS metastases can develop in about 10 to 15% of these patients, indicating that we should be prophylactically screening our patients. Perhaps like small cell, we should be even treating the CNS for sanctuary site in patients who have excellent response. Localized small cell is a poor survival. It's still only 40% and a median survival of about 1.5 years. Extensive stage small cell of the prostate has a median survival about 6 to 8 months. The pattern of spread in CRPC is important, so this is data that is agnostic for phenotype, but just the pattern of spread, and this is Susan Halabi's work, showing that the visceral patients really have the worst prognosis, the red line, as opposed to the green and the blue lines, which are bone and lymph node only disease. So in these liver patients, this is the setting where you may want to consider a biopsy, either for molecular profiling or phenotypic decision making. The clinical phenotypes of potential NEPC, it depends on which center you're at. If you're at MD Anderson, they call it anaplastic prostate cancer, and they define that as one of 7 different definitions, either the pure small cell variant, exclusively visceral metastases, lytic lesions, bulky adenopathy, low PSA production, neuroendocrine markers, and they've thrown CEA in this, or G-related peptide, and a very short interval of castration. And looking at those definitions, all of them were associated with rapid progression. And in their data, they looked at platinum doublets. They found that docetaxel carboplatin, carboplatin etoposide provided some palliative benefit, but really a fairly rapid progression, low response rate, progression-free survival of 4 to 6 months in these patients. There is single-agent carboplatin data. Is certainly better tolerated than these doublets, and I've used it in many patients. But we really need trials that can move beyond just 4 to 6 months of benefit, even with platinum doublets. One trial that caught my eye over the past year is the gemcitabine oxaliplatin data. This really was a Korean trial, only 33 men, but had a interesting approach. These were high-risk viscerotropic patients, high LDH, fairly low PSA. These were all post-docetaxel patients. PSAs were relatively high, so kind of indicating that these were somewhat of an intermediate phenotype. They had a progression-free survival with this GemOx regimen of 5 months and a survival of 17 months, pretty well tolerated. A PSA response rate was seen in over half of patients, and radiographic PRs in 82%, which is almost unbelievable. So I have considered this in some patients. I just show this data because it's intriguing. It's actually in the NCCN guidelines now as just one of the many options that a provider could consider for a treatment refractory patient. The MD Anderson group has also published the Kabazi Carbo trial. This is not yet published, but only in abstract form. This is a randomized phase 2 trial looking at Kabazi-Taxol versus the combination. This was Kabazi at 25 plus carboplatin at AUC of 4 every 3 weeks with growth factor support. The PFS was improved with the addition of a platinum from 3.8 to 5.7 months, and the RECIST partial response rate improved from 14 to 52%. Overall survival data was immature, and they do plan to do a much larger randomized trial and to follow these patients. Again, these were patients that met the criteria per MD Anderson for anaplastic disease, not the West Coast Dream Team criteria for intermediate or pure small cell. So it's really depends on what center you go to, whether you get enrolled in this kind of trial or that kind of trial or that kind of definition. So we really need standardization across the globe for this disease. I'm going to finish with a couple clinical trials. So aurora kinase inhibition, again, Misha has shown that in xenografts and in patients, you can see amplification in the aurora kinase gene locus as well as NMYC, and you can reverse that and inhibit the growth and the tumor size with an aurora kinase inhibitor. You can actually start to see the reversal of the phenotype where synaptophysin is lost with the aurora kinase inhibitor. And this was the DoD consortium trial that I think is finishing next week. We've been participating in it. It's a 2-stage design, enrolling patients with a range of phenotypes, small cell, neuroendocrine histology, liver metastases without PSA progression, or a high serum chromogranin or non-specific enolase. They've been treated with the Millennium agent, 7 days repeated on a 21-day cycle. The primary endpoint is progression-free survival now after an amendment. And really this is completing. So within about a year we should have results of this, and we should know whether this will have activity as a targeted therapy for this disease. Certainly this is not reversing P53 or PI3 kinase or the EZH2 lesions that we see in these, but it is targeting at least one of the lesions that's amplified. Whether that's causal will be really shown in this kind of trial. Just finish up with limited stage small cell. So we've all seen patients where we're really not sure what to do. These are patients who present with small cell of the prostate, no metastatic disease. We call that limited stage disease. And they're treated again per NCCN guidelines as if you had a localized small cell of the lung, where we would typically start with a systemic therapy, typically a platinum-based chemotherapy followed by local regional therapy, either radical prostatectomy or radiation therapy. The outcomes, despite this multimodality approach, at least in the MD Anderson series, which is the largest in the world, has been pretty dismal. Progression-free survival, even in localized small cell, of 10 months, and a disease-specific survival of little under a year and a half, indicating that this is really a systemic disease from the beginning, even if you can't see it. And so the treatment of these hybrid small cell adenocarcinomas should really consider the highest grade component in the treatment paradigm, and we should consider novel approaches to these patients. So in summary, before dinner, there's really no level 1 evidence to treat these patients, and the outcomes remain poor. The level 2 evidence is supportive of platinum singlets or doublets, and there's a list that you have here that you could choose from, but really it's referrals to clinical trials. As Jody may have touched on, we do see some immune signatures in these patients with neuroendocrine prostate cancer. We really should be considering some of the novel targeted agents that are starting to be successful in small cell lung cancer. As far as immune therapies, we should be considering really out-of-the-box approaches for these patients. But I encourage all of you to refer your patients for trials and to think creatively about these patients as we're starting to see more of them. So that's it for the session. Any questions? Karen.
One quick question. Great talk. In the aurora kinase trial, you mentioned P53. Did you look at RB status in those patients?
Yeah, I think they're really doing RNA sequencing on all the patients.
Okay, so you'll see it, because even outside those that have aurora kinase amplification, aurora kinase A is tightly E2F regulated, and it's an important component of tumors that are driven by RB loss.
Yes.
So I would predict that RB may correlate with response there. Be good to look at.
If there are responses, yeah.
One hopes.
Just as a quick comment, you showed that localized disease and said it looks pretty bad, but that's actually identical to small cell lung cancer of the lung, limited stage. So when you look at it, it is behaving like small cell carcinoma of the lung.